Hello, everyone. My name is Leah Ashragi, and I am the Senior Director of Clinical Research at Dr. Susan Love Foundation for Breast Cancer Research. I am thrilled to be here today to discuss our metastatic breast cancer collateral damage project. The mission of Dr. Susan Love Foundation for Breast Cancer Research is to end breast cancer. As we work towards this goal, we drive collaborative, cutting-edge research with non-traditional partners, shed light on the collateral damage of treatment, and actively seek ways to diminish it, and interpret science to empower breast cancer patients. Through our signature program, the Love Research Army, formerly known as the Army of Women, we are committed to encouraging and facilitating breast cancer research in all people, regardless of age, race, ethnicity, gender, sexual identity, with or without a breast cancer diagnosis. Through the Love Research Army, we thoughtfully engage over 380,000 members by providing them with ongoing, real-time access to an array of studies. The impetus for our MBC Collateral Damage Project was Dr. Susan Love's own experience with leukemia. It put her on the other side of the table and made her very aware of the collateral damage of cancer treatments. She entered a new world with her diagnosis, and it opened her eyes to the patient experience in unexpected ways. I think we all know that disease is so much more than the diagnosis. There is an unspoken cost of the cure and all the collateral damage that comes with the disease and its treatments. We need to talk to patients about their experiences and do everything we can to democratize research. With things like crowdsourcing, we can hear directly from the patients about their experiences and the issues that are important to them, not just what the doctors think are important. So, what is collateral damage? Dr. Susan Love Foundation defines collateral damage as the unintentional consequences of cancer and its treatments, which encompass the physical, functional, psychological, emotional, social, vocational, and financial concerns of affected people. We're not talking about the side effects such as nausea and vomiting or hair loss, which are typically transient, but the long-term consequences of therapy, such as chemo brain, neuropathy, and the financial impact. Some of these changes will resolve, and many will not. In Dr. Love's case, it has been 8 years since she received chemotherapy to treat her leukemia, and her sense of taste and smell still haven't returned. So while there is overlap with quality of life, collateral damage is really looking at patients' negative experience. Now, how did we get started? We originally were simply interested in studying quality of life in people with and without breast cancer. For this, we conducted crowdsourcing to develop an extensive quality of life questionnaire. We wanted to study what was important to people with breast cancer, not just what we thought was important. In the fall of 2013, we partnered with 19 other breast cancer organizations and put out a call to breast cancer survivors to send in their questions about the side effects of their treatments. With more than 3,200 people responding with over 9,000 questions, Jeopardy style, we had a lot to work with. The crowdsourcing highlighted the lack of information or understanding about the short and long-term impact their treatments would have on their quality of life. We took all of that data and developed a quality of life questionnaire, which we included in our online The Health of Women study. The How study was open to everyone, both with and without a breast cancer diagnosis. It was important to us to hear from people who have undergone treatment and those who haven't. Are memory issues simply a matter of getting older, or does cancer treatment make memory issues worse? The survey covered a wide range of topics, as you can see here, including chronic conditions, finance, reproductive health, and communication. Over 11,000 people completed the survey, including people without a history of breast cancer and people diagnosed with both early and late stage breast cancer. Their answers revealed, not surprisingly, that metastatic breast cancer patients have a significantly diminished quality of life compared not only to healthy people, but also to people who have had a primary breast cancer diagnosis and treatment. The gray section of the bar is poor overall quality of life, which you can see is highest for MBC patients. As a result of those findings, we decided to focus next on metastatic patients, and to do it by taking a fresh approach that would focus more on the issues that really matter to patients than on what researchers may think is important. Through free text responses, they communicated multiple areas of collateral damage not standard in published measures. As treatment for MBC improves and people are living longer with the disease, managing and minimizing collateral damage resulting from sequential and often continuous treatments is crucial to improving quality of life. The aim of this project was to characterize the unique experience of MBC to identify and address potential areas of need in this underserved population. This project had a lot of moving parts, and here are the beginning stages. As I mentioned earlier, the first step was to clean and analyze the House study quality of life data. We then convened an advocate task force to support the project. The next steps were to crowdsource input from the metastatic breast cancer population, analyze that data, and then develop the qualitative questionnaire. We engaged a highly diverse advocate task force comprised of 11 women and men with metastatic disease themselves and one caregiver to guide us and provide their insights at every step of the way. I show this slide to both thank those who selflessly donated their time and energy to this project and also remember those we have lost. It always serves as a reminder to me of why this work we do is so important. Here is an overview of the crowdsourcing. 353 people with MBC completed our 5 open-ended questions. For example, we asked, please share the most significant collateral damage you have experienced from your treatment or your metastatic disease. Please put your symptoms and other collateral damage in a list. To analyze the data, the team calculated the word and phrase frequencies and extracted themes and representative quotes. All of these data were used to develop the qualitative questionnaire, and some language was used verbatim. It was critical to include the patient voice throughout this entire process. This word cloud shows free text responses to a question about the most significant collateral damage they have experienced and in what areas of their lives. You'll see the word work is very prominent. This word was used in a variety of ways, including worries about their treatment not working and being unable to return to work. So while it was important to look at the words being used, context was also key. Here are some representative quotes which highlight the wide range of topics being covered. People wrote about loss of financial stability and isolation from former friends, but there was also a focus on the positive experience, with one person stating, "Be hopeful, try not to let the diagnosis define you." From employment achievement and financial concerns to activity disruption and positive experience, we knew we had a lot to cover in the qualitative questionnaire. The next phase of the project was the measure development. Everything we learned from the crowdsourcing resulted in 79 items for our questionnaire, the new measure, which were then supplemented with validated surveys. Our living with metastatic breast cancer subscales were separated into 2 categories outlined here. Part A includes employment achievement collateral damage, financial collateral damage, insurance collateral damage, mortality uncertainty concerns, and activity disruption. Part B subscales were concern for others, social isolation withdrawal, self-concept disruption, and positive experience. We launched the questionnaire with support from the breast cancer community. 515 participants completed it. We then analyzed the data to present and discuss at a 2-day think tank. We included 4 working groups to address key areas of concern in the community. And then the final step is to collate the findings into a comprehensive set of recommendations. Our think tank was comprised of our advocate task force, along with healthcare providers who have also been treated for cancer. We coined them provider survivors. It was crucial to Dr. Love and our team that we address issues from both perspectives of care to ensure that recommendations would fully address patients' needs and could be easily implemented in the current healthcare delivery system. As Carol Meal, one of our advocate task force members, stated, "Every voice counts. Although we share much in common, each voice is unique and adds its own value. I hope our collective voices make an impact." And they certainly did. The 4 working groups were patient experience, including patient-provider communications, psychosocial collateral damage and palliative care, financial toxicity and workplace impact, and physical collateral damage, including reproductive health. Each group was comprised of a mix of advocates and provider survivors and included a moderator from the research team. We held general sessions that provided an overview of the data and then broke up into the working groups to discuss the data through their own lens. For example, how does something like chemobrain impact each of the 4 areas? From there, we came back as a large group and shared the findings. So in summary, our crowdsourcing data indicated that several important concerns related to MBC were not captured adequately in existing measures, so we set out to develop a new one. This new measure yielded 9 consistent subscales. We were able to identify what patients are most bothered by, with mortality and uncertainty as the biggest concern, followed by activity disruption, financial collateral damage, employment and achievement collateral damage, and insurance collateral damage. We also discovered where they showed the strongest agreement, with positive experience, followed by concern for others, self-concept disruption, and social isolation and withdrawal. We were also able to identify participants most at risk for collateral damage, and these included people younger than 50, those with at least 1 child under 18 living at home, those without enough money for special things, and patients with metastasis in bone only or multiple sites. This is an important finding to consider when developing interventions and programs for MBC patients and for doctors to keep in mind when interacting with their patients. When looking at the positive experience subscale, we learned that demographic and medical characteristics did not differentiate participants. The think tank was a transformative experience for everyone, and we learned so much over those 2 days. These next 2 slides cover some global themes we identified. As you can see, they cover a wide range of topics, including insurance, communication between doctors and patients, and the need for an expanded medical team to address quality of life and collateral damage concerns. Many think tank participants shared personal stories which were incredibly impactful. A breast surgeon became very emotional during one of these sessions and told the audience, "I thought I got it. I thought I understood, but I didn't," and then promised to take everything she learned back with her to her practice. These themes here touch on what can be done to better support patients. The working group I moderated discussed using geriatric care as a model that could be adapted to the MBC patient population. Other groups discussed group appointments used in obstetrics care that could be incorporated into MBC patient care. A key lesson from our conversations is that the burden should not be on the patient to navigate the system. Resources such as patient navigators, financial planners, patient advocates, a palliative care team, and more should be available to support the patient's needs. Here's a quote from the think tank that really sums up what patients need. Strategic, holistic, dynamic, personalized, short and long-term plan to maximize survival and quality of life with a proactive, preventive, and responsive team approach. And that came from Dikla, who is one of our advocate task force members. Dr. Love has often said that to reduce collateral damage, we need researchers to use the same technologies they are using to develop precision medicine therapies to figure out who is more likely to develop side effects from a specific treatment. She is delighted to see those types of studies are now being done. As these studies are being conducted, we need to make sure that the patient voice is incorporated. Further, we must ensure that they include diverse populations. It is critical that all voices are heard, and that means all races, ethnicities, genders, sexual identities, and ages. We need to challenge the scientific community to launch studies that are as inclusive and diverse as the people that breast cancer affects. Thank you to the amazing team who made this project happen, the MBC patients who participated in the crowdsourcing and qualitative questionnaire, the MBC Advocate Task Force members who gave so freely of their time and input, our think tank participants who shared with such honesty, our incredible collaborators who worked so hard on every aspect of this program from start to finish, our research team, and finally, our generous sponsors. Thank you so much for your time.